Hi, welcome to my today's classroom. Today I will be discussing a case of 71 years old female whom I saw about an year back. This 17 years female presented with history of dysphagia, and that dysphagia was of stage 1. That means she was complaining of sticking sensation in throat and retrosternal region, upper part of the retrosternal region. This lady also complained of long-standing reflux. She was also complaining of dyspepsia. Dyspepsia, I mean to say, any abdominal discomfort is known as dyspepsia. If there is burning sensation in abdomen, that is a dyspeptic symptom. If there is pain in abdomen, that is a dyspeptic symptom. So any type of abdominal weight type of abdominal complaint is known as dyspepsia. So this lady presented with dyspepsia and burning sensation in epigastric region. She also complained of loss of appetite, and these all complaints were persisting since last 1 year. Now, as the lady was tobacco chewer, she was chewing tobacco for about 20 years. So, I have to think on lines of malignancy also. So, when I examined this patient, I saw that in general examination she was anemic, her conjunctiva was pale, and clinically it was evident that the hemoglobin might be of 8 to 9 gram per dl. When I examined her further, her blood pressure and all vitals were normal. On abdominal examination, there was nothing specific. So I thought that why should not I do first upper GI endoscopy. So I advised her upper GI endoscopy to confirm the diagnosis. Because here I kept four possibilities. Number one was some malignancy which has led to dysphagia because she was a tobacco chewer. Second possibility I kept was of some esophageal webs in the pharyngeal region, some webs because of iron deficiency anemia as she was anemic. And there was chronic loss of appetite and dyspepsia. I thought that probably might be some chronic type of lesion in stomach. So these were the findings, and I thought on these lines. When I advised her for upper GI endoscopy, she was reluctant for upper GI endoscopy. She denied for it. So I advised her first for complete hemogram and barium swallow. Now in the complete hemogram and barium swallow, I saw that in hemogram anemia was of megaloblastic type, and when I saw the barium swallow, barium examination of esophagus, there was a horizontal ridge-like filling defect in upper part of esophagus, somewhere near the cervical and pharyngeal region. There was a horizontal filling defect. When I discussed with radiologist, he kept possibility of webs. So I thought that still to confirm I will have to do upper GI endoscopy. But when we do upper GI endoscopy, these webs they break off, and it is difficult to demonstrate with upper GI endoscope. But still, as I was thinking on lines of malignancy, I had to go for upper GI endoscopy. Somehow, I managed to convince this lady. I did upper GI endoscopy. And what I found in upper GI endoscopy, in the pharyngeal region, there was nothing. There was simply mild inflammation. As such, there was no obstructive lesion. So malignancy was excluded. I further went down. When I went down in the stomach, when I went down in the region of G junction, I found that that area was lax, that G junction was lax, and that G junction was lying little bit above the normal position. The normal position of G junction is about 40 centimeters from incisors. When we put upper G endoscope, it is 40 centimeters from incisors. And whenever this level goes above, that is, say, if it is about somewhere 35 centimeters, then we keep possibility of hiatus hernia. So I saw that during act of reflux, the hernia was coming up, very small hernia, and that area was lax. So cardiac part of the stomach was coming up during reflux. So here it was confirmed that there was mild inflammation in the esophageal region. I couldn't demonstrate any web in that case. And when I went down, I saw that there was reflux phenomena, and there was a small hiatus hernia. When I further went down, I saw that in the stomach, cardia was going up during reflux. Otherwise, it was normal. There was no inflammation in that area. But when I observed fundus of stomach after inflating it, I saw that the gastric rugi were not so prominent. The stomach was little bit of flat type. I further proceeded down, and when I saw in the body of stomach and antral region, there was mild inflammation in that area. Otherwise, nothing specific was there in that area. So as there was gastric rugal atrophy in the fundus, I took 2-3 pieces of mucosa. I took biopsy from that area and sent it for histopathology. I further went down into the duodenum. The first part of duodenum was normal, second part of duodenum was also normal, and there was mild duodenogastric reflux. Biliary secretions were coming up in stomach, and probably this was the cause of dyspeptic symptoms. When histopathology report came after 3 days, in that the report was suggesting of atrophic gastritis. So in this case, there were 3 findings. In barium swallow, I found that there was a ridge, a horizontal filling defect, but in upper GI endoscopy, there was mild inflammation in that area. And number 3, there was reflux of gastric contents. There was a small hiatus hernia. And in the stomach, there was atrophic gastritis. So these were the features after investigations. In hematological investigation, there was mild anemia, and that was of megaloblastic variety. So now, in this particular case, on looking to the barium examination, there was a ridge filling defect in upper part of cervical esophagus. So this ridge it is usually seen in Plummer-Vinson syndrome, Kelly-Patterson syndrome, which is seen in iron deficiency anemia. Webs are formed in that area, and these webs may cause dysphagia. Apart from this, in some cases of CA breast or in any cancer of neck or in the region of mandible, if radiations are given, then sometimes in that area there is some degree of such web formation. In few cases, it is also seen that in chronic reflux esophagitis, sometimes there is formation of webs in this upper cervical region. So this formation of webs is number 1 because of iron deficiency anemia, that is Kelly-Patterson syndrome or Kelly-Patterson syndrome. So usually in this Kelly-Patterson syndrome and Plummer-Vinson syndrome, we get such types of webs. Number 2, this type of webs are seen in after radiation. after radiotherapy and may produce dysphagia. And in cases of reflux esophagitis, sometimes such types of webs are formed. So in differential diagnosis, you will keep possibility of Plummer-Vinson syndrome or Kelly-Patterson syndrome, one and the same thing. Number two, you will keep possibility of uh, of the formation of webs because of radiation therapy, radiotherapy. But in this case, as such, there is no history of cancer, there is no history of radiotherapy, so it was excluded. But in differential diagnosis, you will keep possibility of radiotherapy induced web formation. And number three, reflux esophagitis may produce such type of webs. So in this case, there was long standing history of reflux phenomena. So there is history of reflux esophagitis in this case, gastroesophageal reflux disease. So you can keep possibility of gastroesophageal reflux disease as one of the cause of cervical web formation. Now when we see to the hematological examination, it was not suggestive of iron deficiency anemia. So Plummer-Vinson syndrome was excluded by this hematological examination. Now further, such type of appearance in barium is also seen sometimes in redundant mucosa of that region. That in that particular region, there is redundant mucosa. That mucosa, what we can say in the anterior wall of pharynx and esophagus, there is undulating type of mucosa. It is hanging from anterior. It is hanging down from anterior side to posterior side. So this type of undulating mucosa is seen in endoscopy, but it was not present here. So undulating type of mucosa is another differential diagnosis. So like this, the differential diagnosis related to esophagus were number one, Plummer-Vinson syndrome, it was excluded. Radiation therapy, which is causing formation of web, that has also been excluded. And reflux esophagitis might have produced such type of webs. Number four is redundant mucosa of that region, that was excluded by upper GI endoscopy. So like this, one by one, I excluded all these possibilities. Then when I saw the fundic region of stomach, it was atrophied. And when biopsy was done, it was atrophic gastritis. So another possibility was atrophic gastritis. That was the endoscopic diagnosis and histopathological diagnosis. And that might have caused the megaloblastic type of anemia because of abnormality in absorption of vitamin B12. So in this case, these were the possibilities. But as there was history of weight loss, I in clinical examination, after clinical evaluation, I kept possibility of malignancy of stomach. But here on upper GI endoscopy, there was no malignancy, and even on biopsy, there were no features of malignancy. But in cases of chronic gastritis, atrophic type of gastritis, later on, if this doesn't improve and if it persists for a long time, then there is possibility of conversion of this atrophic type of gastritis into malignancy of stomach. So these are all possibilities in this case. Now after this, when I treated this patient I gave injectable vitamin B12 for about 15 to 20 days. Anemia was totally recovered, and with the help of proton pump inhibitors and prokinetic agents, I treated for the reflux phenomena. That was also well controlled, and I saw that after about a month or so in follow-up, she improved a lot. But as one of the cause of atrophic gastritis is H. pylori infection of stomach. H. pylori is normal commensal of stomach. So sometimes it produces chronic type of atrophic gastritis. But in histopathology, there was no evidence of H. pylori, and even in the breath test which I performed later on, there was no evidence of H. pylori. Even serological test was negative. So I didn't proceeded to give triple therapy. I never give triple therapy in this case, and as it was proved that there was no evidence of H. pylori. So after treatment with simply vitamin B12 and proton pump inhibitors and prokinetic agents, patient improved within a month. She gained weight and dysphagia totally disappeared. Thank you.